Bene, ora iniziamo. Il professor Guidi vuole introdurre, introduco io come vuole. Sì, inizio io. Ecco, è un onore per noi iniziare con una lezione magistrale del professor Simon de Lusignan dell'Università del Sardi, Data Sharing, the Theory and the Practice. Chi doveva prendere la cuffia, spero che l'abbia presa. Simon? Lui da tanti anni si occupa di database e di un rapporto fiduciario con i medici di famiglia, diciamo, raccoglie dati. Please, Simon.
Good morning, everyone. And I'm very pleased to be able to come and speak to you this morning. Mouse, do we have a pointer that I can...
I ask.
Okay, thank you. Shall I?
Okay, you start, yeah.
Anyway, it's a great pleasure to be able to speak to you this morning. And what I'm going to talk about is data sharing, the theory, what the great and good people in the world are saying, and share with you some of the practical experience and the lessons from the English NHS. There'll be two parts to my talk. The first part of the talk will be, if you like, theory, and I'm going to share with you the first and second laws of informatics, which are very pertinent to this discussion, and then talk very briefly about some of the principles of medical ethics that the World Medical Association is currently consulting on around health databases and biobanks. I'm then going to talk about some examples of using routine data from the English NHS. I'm going to talk about two problem projects, the summary care record and care data, and also about some of the successes of the use of data, the use of data within the RCGP Research and Surveillance Centre, where routine recorded primary care data is the primary source of public health data, and also the use of hospital data. A brief personal introduction about me. I'm a family doctor. The picture on the top right of the screen is my practice, where I've practiced for nearly 30 years. And then I'm there 2 days a week, and the rest of the week I'm a professor of primary care and clinical informatics, very involved in routine data for surveillance and how you use real-world evidence to measure quality and achieve quality improvement. And I'm also quite involved in areas of scholarship too. Some brief theory. I don't know if you've come across before this idea of the first law of informatics, but Johan van der Leij, who's one of the most distinguished informaticians, stated this first law, that you should only use data for the purpose for which they are collected. And if another purpose wasn't defined prior to the collection of data, then the data should not be used. And the context in which he was saying that was the context of clinical data. And I'll perhaps, for those of you who are clinicians, give the example of asthma. In my practice, all the doctors are trained in exactly the same way, but we all have a slightly different threshold at which we would diagnose something like asthma, because there isn't a precise blood test or a precise way that you can diagnose it. And so if you take a diagnosis of asthma and just take that and send it somewhere else in the health system many years later, and you don't know the context in which that diagnosis was made, it's very difficult to use that data. And this is what Johan van der Leij was getting at with this law. I, of course, like to be argumentative, so suggested that there was a second law of informatics, which says that if you understand the context in which the data is recorded, then you can ignore Johan van der Leij's first law. So it's just to try and set things thinking about how when we share data, the people using it later may not understand how and why it was recorded. The next bit of, if you like, theory I want to talk about is a current consultation going on from the World Medical Association on using health data. And they've set out a number of principles, and I'm just going to pick out some of them which I think are very important. The first statement they've had is to say that really the overarching ethical framework is the Declaration of Helsinki, which I think everyone involved in healthcare and healthcare research is familiar with. But I'm picking out 5 other things that they have said should be part of our worldwide ethical framework. One is the second one here, that physicians have obligations of stewards of data, protecting privacy and ethics. Now, I don't think me or many of my colleagues back in England think of themselves as the stewards of our patients' data. They have a statement about how data should be anonymized, which I think most people would agree with. Interestingly, they have a statement about public health, saying that you can use data perhaps without consent where there is clearly identified an immediate public health threat. I don't actually agree with that. As someone who works with data, unless you know what normal levels are, how can you pick a change in level of something? Within the network that I'm involved with, if we'd not had all the year-round data about influenza-like illness, could we have spotted the swine flu epidemic when it came in 2009? So I've written in saying that Statement 19 needs some further thought. Statement 21, that there should be an ethical process around the use of data. And Statement 26, that there should be a legal basis for data collection and use. So that's that sort of current picture on how people are thinking about secondary use of data. I'm now going to talk about use of data in practice and a couple of failures. And I'm going to talk about some challenges first, before some successes with data in the English NHS. I'm going to talk about the challenges that arose from a major programme in 2002 called the National Programme for IT, but particularly within it, the Summary Care Record. And when the Summary Care Record was launched, it was thought really sensible to make summaries of data available around the health service to help people's care. But it failed, and we'll come on to discuss why. And almost without learning the lessons from that, in 2014, the NHS announced something called Better Information Means Better Care, which in vain involved data sharing. And then after that, I'm going to talk about some successful use of data and data sharing in terms of the surveillance network I'm involved in, the Royal College of GPs Research and Surveillance Centre, and how we've used secondary care data, hospital care data, to look at hospital performance. The English have a habit of conducting experiments using IT on a national scale. Usually when someone goes and sees the Prime Minister and says, "Can I have 40 million and I will save you millions in the health system?" And the 2 challenging projects I want to describe is this National Programme for IT and its Summary Care Record, and the Better Information Means Better Care project. The Summary Care Record was part of a comprehensive programme that was going to make online information available for NHS patients. That part has been successful. It was going to allow online booking of specialist care by GPs, which was a disaster. And it was also around this Summary Care Record, which was a centrally held care record linked to a secure web space a patient could have called their health space. And the idea was it would contain key information from GP records, so if you're ill somewhere away from home, your data would be available and it would be there for your care. But it was very interesting that it was a program that patients simply didn't engage with. It was poorly communicated. No one knew how to engage this summary into clinical workflow. There were major national opt-out campaigns. It had a high cost. People found it difficult to use, and this ended in costly failure. And it's something perhaps to realise that someone can come up with a bright technical idea and the use of it and the implementation of it doesn't always work. The next costly failure that we're running through at the moment was the idea that we would create a national system called care.data that will make data available for approved bodies, research bodies, but perhaps also the pharmaceutical industry and other bodies. And this has really ground to a halt through a complete lack of public support. And we currently have, because patients can opt out, around 6% of the patients in the practices that contribute data to the RCGP opting out of data sharing as a result of this program being launched. It's been reined right back and made much smaller and having a pilot in 2 areas, but one feels people are looking to get out of it. These 2 examples, to me, suggest that whatever the legalities or the bright ideas people have, if you like, the use of data must align itself with the public and what the public will engage with and find interesting. I'm going to move on briefly to some successes. A lot of people use primary care data for research, and there's a whole list of very successful primary care databases in England. Perhaps CPRD is the one on whom most research is done. One of these is the RCGP Research and Surveillance Centre, and we extract over 1 million records a week, principally for surveillance of infectious disease, and our practices who've been in the network some time get feedback about data quality. We know who the practices are, and if something strange is reported, we then contact the practice and ask them about it. What's unique about this network is our practices are willing to collect microbiological samples in this top ring here. So our practices, for example, who are involved in flu surveillance, will take up to 10 swabs per week of patients with influenza-like illness, and they'll take more swabs in children if there's family spread or spread within a nursing home. And we also collect microbiological samples for a gastroenteritis study, for chlamydia resistance, and some other projects. We have a lot of illness data from the primary health care record, and we're also quite careful to try and record in our practices about vaccine exposure so that we can look at the interaction between them. We have a regional setup of practices across England and some in Wales, and we have in excess of 100 practices. It's going to rise to 200 this year, over 500 doctors, and a population of in excess of 1 million. Last week we reported data on 1.2 million patients. This is an example of the sort of data that we produce. We produce a weekly report, which is the header of it. And what I've got below here, which I'll try and talk through, is what's happening through the winter. So along the bottom here you have the week of the year. That's, if you like, week 1 is week 1 of the year. And these are the weeks running up to the end of year holiday. This is the rate of influenza. And on a different scale, these are the swabs taken by our practice, the nasopharyngeal virology swabs. And the purpley ones here are the ones that are positive for influenza A, and harder to see are the ones that are positive for influenza B. And it's very interesting how good our practices are at spotting flu. During the flu weeks, the positivity rate is around 60% for our swabs. And from that, we generate research on the effectiveness of immunising children against flu. That has been quite interesting. Up until a few years ago in England, we just immunised high-risk adults. But we realised, and those of you with children will realise, that children, as they spread snot and other things around, are the vectors of flu, and that immunising children, particularly at sort of younger pre- and primary school age, seems to have an impact on flu transmission around the community. And as you perhaps see from the authorship, that this is work done carefully with Public Health England, and Richard Peabody in Public Health England is the lead for a lot of this work. Moving on to secondary care, within secondary care, there are statistics collected about all admitted patient care, outpatients appointments, and A&E attendance. And this data has been collected since 1989, and it's a good source of, if you like, administrative big data. And it started to include patient-recorded outcome measures. One of the most famous users of this data is an organisation called Dr. Foster, and this is probably their most famous detection of difference in rates. And using routine hospital data, Dr. Foster for years have done league tables of hospitals. They showed in 2007 that a hospital called the Mid Stafford Trust had a standardised mortality ratio that was much higher than other hospitals. So this line along here is the standardised mortality ratio for all the secondary care trusts within England, and this was this Mid Staffordshire Trust. And this excess rate is thought on final analysis to have equated to around 1,200 excess deaths within that hospital. And this is an example to me where sharing a standard set of routine data has had a profound positive impact on monitoring hospitals. So I'll move on to my summary. What I think we've learnt in England is how that things often don't work out in real life how you plan they might happen. You would really expect that a summary of person's data, always available, would really be helpful and would be a great success. But until you think how you might collect that data and make it available in a usable way, you don't know until you try. And it was a shame there was no experimentation on a smaller scale, that this just proved not to work. Now, interestingly enough, a lot of the campaigns around the time focused on the summary care record being created without consent and the patient not having control of what was there. But in parallel with the summary care record being created in England, a medical dossier was being created in France, which was individual patient consent and choice of what went into it, and that equally made little progress, with a similar proportion of the population signing up for it, i.e. a very small population, as happened in England. An initiative more recently to create a product called care.data, which was about drawing together data to make it more accessible and usable, has resulted in enormous public backlash and implementation delay. And I think this is very important and something we should be aware of if we have an ethical principle as physicians that we are the custodians of people's data. But notwithstanding these problems, there's a lot of successful use made of health data, and I've cited the RCGP surveillance network that I'm involved in as one example, and the use of hospital data to flag variation by Dr. Foster as another, but there are many, many other examples I could have come up with. I think one of the key things with sharing and using data is, does it, if you like, meet the public interest test? And a lot of the people who write about the public interest say that you really have to define the public interest in terms of what is acceptable to the public at that time. You can't sort of, in theory, remote from population and citizens, decide what's good for people and do it, because we have a society, certainly in England, that won't accept that. Currently, legally, won't that. Of the record about them. We all talk about needing standards for anonymizing data, and in England we talk about pseudonymization to make it very confusing for everybody. And we need to have and work together to develop clear global standards that are acceptable to the population about this. And if we fail to do this, I think it will become hard to share data. There's confusion, and people talk a lot about how patients own their own data. How can a patient own their own data when it's me as a doctor who's written down 30 words about them or typed them into the computer and stored it in the computer? Isn't it my data as the recording person? And it is because the record is created by healthcare professionals that we end up with a situation where data controllers in healthcare organisations decide whether to share data rather than individual citizens. But it's clear whether or not the concept of data ownership exists, and it probably doesn't exist legally, patients need to be able to control data about them. The key messages from my talk are that IT system experts are very good at logical thinking, but not so good at constructing social solutions and appreciating other people's perspectives. And that's really the story of the summary care record and care.data. People who were wise, bright consultants who had set up, the people who set up the first national programme had set up the London congestion charge. So they knew how to do technology. They had made a system that clocked whether cars drove into an emission zone or not. And because they were IT experts, they could do health. And they'd not thought about that health is about constructing social solutions and appreciating other perspectives. And I go on to say that there's this inherent mismatch, to further reinforce this point, between the mode of thinking required to develop robust social solutions, and medicine is a social process. Yes, we have evidence, well, not anti-evidence, but how we engage with our patient, I think, is a social process. And you know, we need robust social solutions that are required for the technical things we wish to achieve. And I'm a great fan of Mark Berg, who wrote very clearly, and his book is referenced further up in his talk. His book is called Rationalising Medical Work. But I think we need to think very carefully about greater use of socio-technical theory if we're going to inform effective practice and the deployment of information technology. I'm going to stop there, and I hope I went slowly enough for those of you who are on translation, and I look forward to any questions. And I'm also very happy for people to email me, or if you're flying through Heathrow, we're only 30 kilometres away, want to come visit the university or the RCGP, any of you will be very welcome. Thank you.
We're fine.